Thank you very much. The pointer and the advance the slides. Oh, this does it. Yeah. Okay, great. Good, thank you. So thank you everyone for sticking around until the end. Sometimes my trainees say I shouldn't post on Twitter because everybody thinks my patients are under really bad control. So I'll tell you right now, some of them are doing well. Not all of them, but some of them. So I wanted to talk about systemic sclerosis, and I'm trying not to repeat what's been already talked about over the last couple of days, but to maybe enhance our knowledge, have a little bit of reinforcement, and tell you where we're thinking over time, where things are changing. Down, got it. Okay. These are my disclosures. They're probably the same as the last 2 days. They haven't changed. So I wanted to talk about, we're going to talk about treatment in systemic sclerosis. So really, what is our clinical management? What are we thinking about an organ system? And where are we thinking in the future? We want to look at screening, and we want to have an update on knowledge of emerging treatments, which I won't spend too much time on. So I think we all are highly aware that I'm going to call systemic sclerosis from now on in the talk, I'm going to call it scleroderma. But I'm talking about systemic. I'm not talking about morphea. I'm not talking about linear scleroderma. So scleroderma, I mean systemic sclerosis. 3 main parts of the phenotype: autoimmunity, ANA, maybe other autoantibodies; fibrosis, the laying down of collagen and multiple organs; and also vascular change. So not atherosclerosis like LES, it's vascular change that obliterates. You basically get intima proliferation, adventitia proliferates, the media proliferates, and you can basically obliterate blood vessels. And we all know of patients that have more vascular or more autoantibodies or more fibrosis. So those 3 components should be present, but not always to the same degree in the patients. So if I was asked to give this talk when I started to practice, it would be really short. It'd be about 1 minute long. I'd tell you a bunch of negative trials of things that were kind of odd things to try, and they didn't work. So fortunately, we've come a long way. So we developed the classification criteria for scleroderma, systemic sclerosis, in order in a rare disease to include the most patients who had it. So the old criteria worked very well if you had diffuse subset, because the old criteria were having sclerodactyly proximal to the MCPs, which could be limited or diffuse, or sclerodactyly and pulmonary fibrosis. They were kind of the main features. So when we developed the criteria, we wanted to keep in mind autoantibodies, vasculopathy, fibrotic change, and we wanted to keep in mind the organs that were common, like Raynaud's, and the organs that were rare but very important. Now, not always everything in scleroderma got into the criteria. Scleroderma renal crisis isn't in our criteria. Rare, important, life-threatening, we'll talk about that. GI involvement didn't get in here. Why? Because either the frequency or the overlap with other features that were already in the criteria. So basically, that's our criteria, so you need 9 or more. A higher score doesn't mean necessarily you're worse, and you score the highest in each group. So skin thickening, fingertip lesions or ulcers or pitted scars, telangiectasia in a scleroderma-like pattern, either mat-like or dot-like, abnormal nail fold capillaries, pulmonary fibrosis, or proven pulmonary arterial hypertension, Raynaud's, scleroderma-specific antibodies. And obviously, these will be revised over time if we develop more antibodies or more ways of making a classification. There are future directions as well. So the EULAR-USTAR group has been very active in VDOS, very early onset of systemic sclerosis. The problem with VDOS is it's detecting patients that are probably limited cutaneous systemic sclerosis. They might have puffy fingers, Raynaud's, centromere ANA, and nothing much is happening until you follow over time. Whereas if we're looking at the diffuse subset of systemic sclerosis, often Raynaud's onsets within a year of your systemic sclerosis. In limited, it onsets often 8 years prior. We also think of overlaps. We think of our subsets of the diffuse and limited subsets, which I'll talk about. We think of scleroderma, systemic sclerosis without skin involvement, so SSC, cine scleroderma. So as far as you're concerned, SSC, cine scleroderma acts like the limited subset. The overlaps can certainly act like whether they look like they're diffuse or limited with the extent of skin involvement. Much more recently, EULAR-USTAR has looked at subsets performing better on antibodies than on skin. I think it's true that the antibody subsets are really important. RNA polymerase III, almost mutually exclusive with centromere. SCL70, not common to have with centromere, almost mutually exclusive, so different categories. However, when they looked at skin, they just said an arbitrary skin score above or below a certain amount. If we did a continuous skin score, then the skin score in early disease would also be very prognostic for the near and the far future for many patients. So I think we're looking at antibodies to classify or stratify patients and skin involvement, and that is in evolution. So I'm going to talk about limited and diffuse. So limited cutaneous systemic sclerosis and diffuse cutaneous systemic sclerosis. Easy. It's divided by the maximum extent of skin involvement. So as soon as you have above your elbows or above your knees or truncal involvement, by definition, you're diffuse. Of course, diffuse usually starts distal and goes proximally, and when you're improving, you usually go proximal and to distal for improvement. So areas that improve are often the least affected. Limited is not proximal, so it's not upper arms, it's not upper legs, it's not on your chest, but limited can still be your face and your neck to your clavicles. So it's important to kind of stratify, and it's by the highest amount. Then there's indeterminate or intermediate, where maybe you have skin involvement to your forearm. Is that person in 2 months going to be diffuse, or are they going to stay there? So these things are of prognostic importance and important for what we screen. So we also look at the subsets. So almost everyone with systemic sclerosis has a positive ANA. If they don't, question the diagnosis. Almost everyone with systemic sclerosis, scleroderma, has Raynaud's. If they don't, question the diagnosis. But beyond that, there's different distributions of organ involvement. The most important thing to tell you is you don't want to have a patient with diffuse. They do worse than limited. They're about 1/3 of the patients you see with systemic sclerosis, and diffuse does worse on everything except for pulmonary arterial hypertension, might be higher in limited. I'm going to question that in my talk. It might be about equal in limited and diffuse. But renal crisis, heart involvement, lung involvement, severe GI, calcinosis, digital ulcers, poor hand function is all worse on average in our diffuse than our limited. More skin equals worse stuff in general. The other thing is we don't talk so much about CREST syndrome, C-R-E-S-T, calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, telangiectasia, because limited and diffuse both have those features. So CREST used to be what we now would call limited, but those features can be common in limited and diffuse. So we're going to do a little bit of voting here. So diffuse subset of scleroderma has more of everything but. So more, and you can vote, it's just one answer this time to vote once. So it has more of digital ulcer, everything but. So digital ulcers, centromere, interstitial lung disease, scleroderma renal crisis. So people aren't really voting. So the answer is centromere. Diffuse, only about 3% of diffuse subset is centromere positive. Almost 50% of the limited subset are centromere positive. But diffuse has more stuff. If you have more skin involvement, you have more bad things going on the inside of your organs. And the prognosis is worse. So these are data, very old now, from 1988, looking at some of the original registries by Leroy and Rodman, Metzger et al., and looking at the survival. So in every year, year 1, year 6, year 12, and beyond, the limited subset has better survival. Now our survival is improving over time. So these are data from Canada, and we're going from earlier years of publications to more recent years. And I think if we did even more recent one, we'd have better survival. So this is looking at 10-year survival in cross-sectionally, patients followed forward. The limited subset survival has improved. The diffuse subset survival has improved a little bit, poquito. Only poquito. And the causes of death. So first of all the things we see in rheumatology that we follow, systemic sclerosis has the highest mortality, higher than LES, higher than ANCA vasculitis, but not everyone will die of their scleroderma. So about 1 in 6 will die of their interstitial lung disease. About 1 in 6 will die of their pulmonary arterial hypertension, but they can die of other things. And fortunately, survival is better now in renal crisis than it used to be. So when I'm going to talk about treatment, I also think, is the patient early in the disease or late? Do they have certain antibodies that worry me or not, like RNA polymerase 3, but I can't even get that. I can get all sorts of antibodies that are a waste of time in my lab, but I can't get RNA polymerase 3. But certain antibodies, topoisomerase 1, that's SCL70, increased chance of getting interstitial lung disease. So what occurs early, what occurs late, and obviously this is an artificial division. You can get whatever complication occurs at any stage or level of the illness. But Raynaud's is early. Finger ulcers start early, interestingly. Interstitial lung disease often starts early, but it might not kill you till 10 or 12 years because it can start and level and go down like an escalator. Renal crisis is usually early, but it can recur. Later, pulmonary hypertension, it could be from hypoxia, from lung disease. That's the group 3, but mostly I'm talking about group 1, which is pulmonary arterial hypertension from right heart cath proven pulmonary artery pressure high in your lungs. So something like obliteration of your pulmonary vasculature distally that will eventually lead to pulmonary hypertension. Worsening ILD, Sjogren's or Sicca syndrome, more telangiectasia increase with time, and more flexion contractures over time. Not in everyone, but early and late. So these are some of my patients. So you can see the hands at the bottom that have a lot of erythema here. In the bottom, my left, your right. You can see here inflamed skin. Maybe this person has tendon friction rubs. You can see on the bottom as well an early patient with what we call puffy fingers. You can see later a patient with a claw hand deformity, diffuse cutaneous systemic sclerosis. Skin has softened, but she can't get dressed anymore, and she died after a lung transplant from her interstitial lung disease. You can see the patient that no longer can bend their hands or straighten them, the positive prayer sign, and you can see she's lost a lot of her fingertip pulp, digital tuft resorption. So in order, when you don't see a lot of patients with scleroderma, and when you're teaching the trainees, the junior faculty, it's good to think about what can happen, the organ systems involved. That's what we do in LES. We think of that in lupus. We think of it in scleroderma as well. So we developed the 15% rule, and 15% is common. That's 1 in 6 of the patients could have each of these things going on, in some patients, many of them. We got the rule by looking at multiple large studies, so cross-sectional or forward-looking studies of 100 patients or more. So this was a systematic review. So first of all, everybody almost has Raynaud's. Almost everybody has esophageal dysmotility and or bad acid reflux. So that doesn't work in the 15% rule. But 15% will have a finger ulcer just when they come into clinic on any day. So cross-sectionally 15%, but 50% ever will get digital ulcers. Over the time you follow your patients with scleroderma, 15% of those digital ulcers will be complicated. Gangrene, osteomyelitis, tuft resorption, things like that. 8 to 15% of your patients will have right heart catheterization proven pulmonary arterial hypertension. Scleroderma renal crisis is only about 3% cross-sectionally of scleroderma patients. Why? Because it's usually early, diffuse. Cross-sectionally, we have a bias, a survival bias for more limited or around, and limited is about 66, 2/3, 66% of your patients. But in early diffuse subset, 10 to 15% will have renal crisis. And you go, well, we don't see that. Well, we do. It's because they often die of their cardiac involvement. They often present with renal crisis and end up on the the nephrology floor. So that is true, but they do have a high mortality from the other organs involved. Pulmonary fibrosis or interstitial lung disease is about 30% of diffuse, 25% of limited, but in 15% it'll kill them, and 15% is clinically relevant. 15% have inflammatory arthritis. About half of them will actually need disease-modifying drugs for that. 15% will either have myopathy, bland fibrotic, poor prognosis, or an overlap with myositis, PMSCL70 kind of patients, or sorry, PMSCL patients. And about 15% have either sicca, so the glands are fibrotic, so dry eyes, dry mouth, or an overlap with Sjogren's. And sicca symptoms increase with older age, longer disease duration, just like in rheumatoid. So when we're going to talk about treatment, I've talked a lot of stuff. I haven't talked about treatment yet. So you want to say, can I modify the disease? So before I started my lecture, someone said, well, why aren't we treating the limited patients with disease modification? We wait till they have an organ involvement. And it's true, it doesn't make a lot of sense, but we don't have the data. And to do randomized controlled trials, you can't do it on skin score because they have very little involvement. So you have to do long trials to look at whether they get new organ involvement, whether they get less worsening of organ involvement if you treat. So we need to look at those patients, and research is going on to try to look at outcome measurements in that group. But we want to modify the disease. Can I make you potentially live longer, so improve your survival? Can I slow down progression of disease? And in early diffuse, the surrogate is, can we reduce your skin score that's going on, the modified Rodnan skin score? We also think like in LES. We think in LES for lupus nephritis, we think of induction and maintenance. We think about that in some organs, such as interstitial lung disease and scleroderma. Induction, higher doses of mycophenolate mofetil, maintenance, maybe lower doses. Induction, more drugs, maybe maintenance, less drugs or less toxic drugs. And we want to screen for things that we can treat. So if I can screen and intervene early and change the natural history, then I should be screening. So mostly we're screening for early diffuse, their blood pressure for renal crisis. We're screening for pulmonary arterial hypertension by your history, your physical. Hopefully you don't find anything on either because it's screening. We're not investigating yet. And looking at diffusing capacity and looking at the echo. We're screening for lung disease in people who already have lung disease in our early patients, especially diffuse subset. And we're also screening for lung disease if their SCL70 antibody is positive. The other thing is treat what's treatable. When someone comes in and says, I have really bad pain, I can't sleep, I'm worried, my mood's not very good, I go, okay, that's some stuff that maybe your family doctor can help with. Tell me about other things. Oh, my Raynaud's terrible, or I'm getting finger ulcers. Okay, maybe I can treat that. So treat what's treatable and follow the guidelines. So EULAR, EUSTAR have guidelines. The British Society of Rheumatology with their allied health professionals have guidelines. And in France, the French have, I think, recently published fairly excellent guidelines as well. So these are the French recommendations. And again, I'm not going through this whole slide because this is the bulk of my talk. We'll be talking about these areas, but it's very nice. It has cardiac, it has other manifestations like calcinosis. I don't know how to treat calcinosis, so if you do, you can tell me after. GI involvement, skin involvement, kidney involvement, pulmonary hypertension, interstitial lung disease, Raynaud's, and vasculopathy, including digital ulcers. So it's actually very good. It was published in 2021, and it still holds true today, even though some of the treatments were getting more options over time. So I like this one, and it's a good one, I think, for the trainees who are learning about scleroderma. So for skin disease, I think of skin disease in the early diffuse or worsening diffuse. It can be later disease and your skin score is stable at 12 and it shoots up to 22. I'm going to treat you as though you have early disease. I'm going to treat for disease modification to improve skin. When your skin is worsening early, it's a surrogate for new and or worsening internal organ involvement such as lung disease. So later on, when you're 10 years of disease duration, your skin might have regressed, but your lungs can continue to progress. So methotrexate, probably higher doses than our trial. Our trial was only 15 milligrams, so probably 25 milligrams once a week. Cyclophosphamide, but a lot of trend now is looking at mycophenolate mofetil. Mycophenolate mofetil at 3,000 milligrams a day for 2 years, and the scleroderma lung study does hardly anything to skin. It's not great on skin, but it seems to protect and treat the lung disease in the lung studies. Methotrexate has about the same kind of weak effect on skin. Many of us are using rituximab. It's superior to cyclophosphamide for skin and lung disease in 3 randomized trials. 2 are large. Drugs like belimumab are being looked at, but certainly off-label. Stem cell transplantation has data. Maybe JAK inhibitors. Other biologics are being looked at as we speak. A whole bunch of negative studies, unfortunately, and then I'll call it some borderline trials for skin. Tocilizumab P.06, very weak effect on skin. Abatacept included improved function, but in the first year, really no effect on skin at all. So lots of different things that we've looked at. So what experts say to treat systemic sclerosis, first of all, this is old now. So the algorithm used to be methotrexate. And weirdly, when we said to scleroderma experts whether the skin score was low, medium, or high, weirdly, they said methotrexate every time. I probably wouldn't have done that. I would have said really high skin score, modified Rodnan of 32. Maybe I'm going to start more aggressively like cyclophosphamide. However, then they would try MMF, either switching or adding, and these days that would be flipped. MMF, then trying methotrexate potentially in the lower skin scores. Obviously thinking of stem cell transplantation. Does anyone have patients with scleroderma who have received an autologous stem cell transplantation? So we have like 5 hands in the room, maybe 6. So I don't have many patients either. I do have some, but we talk about it. It is life prolonging compared to giving cyclophosphamide for a year in the trials, an upfront mortality, but it doesn't cure the patient. It's very expensive. It has to be in a specialty center. It's just not for everyone. If it was a cure, I'd say go for it. But it does improve quality of life, quantity of life, especially function, skin score, and lung disease. But it's not for everyone, as we know in the room here. Steroids, not usually. There's other randomized controlled trials, intravenous immunoglobulin and other gamma globulins. I hardly would use that. ECP, extracorporeal photopheresis, so phototherapy. We don't have access to that currently. Plasma exchange or plasmapheresis, virtually never order that. So we have some trials that have a little bit of positive buzz around them, positive effect that we don't really use, cost, etc. Then looking at the data, so tocilizumab had a phase 2 study, P of 0.06. Phase 3, they did the very same thing and shockingly got the very same answer, P of 0.06. So you can see here it was mostly monotherapy unless if you really worsened at 24 weeks. If your skin score had worsened enough, you could add MMF, mycophenolate mofetil. So hardly anyone added MMF in either group, more in placebo than in the active tocilizumab. But you can see here the change in skin score was not very exciting, but it looked like the forced vital capacity, the percent predicted, stayed level on tocilizumab and worsened. This was not a lung study, but worsened in the patients on placebo. So in other words, maybe there was a paradigm of prevention of worsening or prevention of new internal organ involvement. Who drove the data? Very few. A small subset of patients drove the data for worsening lung involvement on placebo and improving lung involvement on active treatment. So I think, like when I use methotrexate in rheumatoid arthritis, I usually use combination therapy, irrespective of what the ACR and the EULAR guidelines tell me to do in rheumatoid arthritis. Because in rheumatoid arthritis, combination therapy is always superior to monotherapy in active RA. So I think it's actually a little bit crazy, this is my opinion now, it's crazy to do monotherapy trials in early diffuse systemic sclerosis and expect a home run. Remember, stem cell transplantation was high dose obliterating the bone marrow with multiple drugs, ATG, glucocorticoids, cyclophosphamide, etc., to obliterate and then to change the cells, put them back in, and then hope for the best. It was a multi-drug kind of treatment as well as a radiation. So to think we can make a home run on monotherapy in patients who are sick with scleroderma, to me is kind of crazy. So it is very difficult to treat skin. It's difficult to treat fibrosis. So I think we should have trials of things that you would think about in oncology, like CHOP-R, treating lymphoma with 5 drugs now, not 1 drug. So this is just one little trial. And by the way, my understanding is belimumab is going to do a phase 3 study. That's my understanding. But this was just a little single-site study, but saying early diffuse patients, active disease, randomized to mycophenolate mofetil or mycophenolate mofetil plus belimumab. And you got a 3 times better change in skin score if you use 2 drugs than 1 drug. Their change in skin score on mycophenolate mofetil was the same as other trials that have looked at skin score. So to me, there's face validity. They also did biopsies and turned off some fibrotic genes or reset them better on the 2 drugs more than on the 1 drug. So to me, it's a model of saying more in scleroderma early on might very well be better than less. But people don't always think that way, and they say FDA and health authorities don't think that way. Well, we have to educate them how to think as well. So what do we expect? So this is our treatment effect of change in skin score, the modified Rodnan skin score, from the beginning to the end of a trial minus the placebo. So you can see methotrexate, mycophenolate mofetil, interestingly, oral cyclophosphamide, tocilizumab all line up. Intravenous cyclophosphamide, in my opinion, is weaker than oral because it's less total dose, but it's in the trials that were looked at, it was more effective than, say, methotrexate or MMF, mycophenolate mofetil. Rituximab is about the same treatment effect as cyclophosphamide, and of course, safer and better on lungs, actually, and better on skin, in fact, in the trials. And autologous stem cell transplant is a huge outlier of improving skin by an average of about 20 points over the next year. So we don't cure people. People that get stem cell transplantation often might start with a skin score of 36. So going down by 20 is clinically relevant, but they still have skin involvement. And we just published that this year. So what about stem cell transplantation? So there are actually about 4 randomized controlled trials now, but the ASTIS is the first one. Upfront mortality, 10%, especially in smokers. In the US one, upfront mortality about 5%, the Scott trial. But you can see by the time you're at about 2 years, you've leveled your mortality on the stem cell transplantation. And cyclo, mind you, only for 1 year, the mortality continues to go down over time. Same idea, looking at the Scott, the US trial, a little bit of different regimens. This took an awfully long time to recruit. So instead of survival, they had a composite endpoint where you want more people in the green than in the red. And you can see cyclophosphamide alone, more red. Stem cell transplantation, autologous, more green. Green is not having clinically relevant events such as new or worsening lung disease, survival, new onset of things like renal crisis, heart involvement, etc. And a 5% upfront mortality. Is it a cure? No. Would I send patients more so? I think if it wasn't such a difficult to obtain treatment, it's no fun having the treatment as well, then I think I would send more patients. So I think instead of blasting the immune system, we have to be somewhat targeted, but for multiple targets, at least in my opinion. The other thing is there's a randomized controlled trial going on right now. This is the protocol they registered. This is out of Europe. A lot of centers that do lots of stem cell transplantation saying upfront autologous stem cell transplantation versus immune suppression, not waiting till you fail it, doing it right at the beginning if you have poor prognosis, diffuse disease, rapidly progressive skin, already having lung involvement, a high skin score, things like that. So we will get those answers, but again, for most of us in the room, it won't change our treatment because we might not ever get much access to it. A bunch of negative trials, abatacept. I can tell you in the second year of abatacept study, placebo crossed over, the active patients continued. It certainly looked, in my opinion, looking at the data, that the second year had more improvement on skin. But of course, you drop out if you're doing poorly. So people who are doing a bit better are going to stay in. However, who knows? You can look at the cannabinoid receptor, phase 2 positive, mostly because pain was improved when they did the composite endpoint score, but a little bit better on skin. Phase 3, waste of time, negative. The phase 3 trial, however, they said there was more background mycophenolate mofetil, and that dampened the between groups differences. Well, I already told you, 2 drugs are usually better than 1. So if you have an effective drug, you should still find the effect. So this drug is now killed in scleroderma. What about riosequat? We heard about that the other day from one of the presenters. It was to do an improvement on skin. It's a PDE5-like drug. It's cyclic oxygenase changes, and they wanted to look at Raynaud's and digital ulcers. Anyway, it didn't make much difference between active and placebo. Overall, primary outcome negative, most secondary outcomes negative, and it's not being studied further in systemic sclerosis, but it is approved in many countries for pulmonary arterial hypertension, thromboembolic, and possibly scleroderma and idiopathic pulmonary hypertension patients as well. So lung disease, we think of 15% will have their severe interstitial lung disease, 15% up to that will have pulmonary arterial hypertension, and both things together, bad PAH with bad ILD, 15% of your PAH patients have ILD. 15% of the ILD patients have concomitant right heart cath-proven PAH. So 2 major organ problems is more apt to kill you than 1. So if you have bad lungs and pulmonary arterial hypertension, you really are not going to do well. So screening is not just lead time bias. So by that I mean, if I were going to pick it up 3 years from now, but I screen and pick it up today, and the patient survives 3 years longer if I pick it up today, that's the same survival. It's just I picked it up earlier. We know in the randomized controlled trials of pulmonary arterial hypertension, of whom about 1/3 of the patients are usually scleroderma or scleroderma-like patients, and all those randomized controlled trials, that if you treat pulmonary arterial hypertension earlier in class 2 shortness of breath, as opposed to group 3 or 4 or class 3 or 4 shortness of breath, if you treat earlier, even in 24 weeks, you will have more worsening on placebo than on active treatment. It is not lead time bias. Screening them, you pick them up not so much in heart failure, which is why we're screening, to pick them up when the heart pump still works. You pick them up with a better walk time, with lower brain natriuretic peptide, and overall in a group 1 or group 2 of shortness of breath. Every study that looks at screening says you pick them up earlier and they will do better by screening. So how do I screen? I do an echocardiogram periodically, annually, maybe every 2 years. I do a history, but I also look at a dropping diffusing capacity. We have presented in our Canadian Scleroderma Research Group that no one with an 80% above predicted diffusing capacity as pulmonary arterial hypertension. Their average diffusing capacity is about 55% predicted. The overall cohort average is about 75% predicted. If you have a normal diffusing capacity, you do not have scleroderma pulmonary hypertension. So if your diffusing capacity is always 88% or 98% predicted, and you do long 10,000 step or rapid runs or walks every day, I probably don't need to do echoes as often as if you don't do anything. You watch Netflix because you don't feel good with your scleroderma. So think about it in long-standing patients. So limited patients, we always say, oh, they have more pulmonary arterial hypertension. But it's a survival thing. They start at older age, they get longer disease duration because some of the diffuse patients die, and older age and longer disease duration are risks for sure of pulmonary hypertension. A low diffusing capacity, I said, and if you wanted to screen something very inexpensive is uric acid. So uric acid probably increases with right heart strain before we pick it up. Uric acid in at least 3 studies has been found to be predictive of getting future pulmonary hypertension. I don't mean treating hypertension. Of course, if you're on 3 diuretics, you're going to have a high uric acid. I mean predicting pulmonary hypertension. So this is some data that we're going to have a hard time to publish because we said you can only get pulmonary arterial hypertension in any year. So this is up to 600 months of follow-up. If you, so 10, 12 years, whatever it is, you can only get it if you're alive at the time. So if we look at the diffuse patients and do a competitive survival, we found the incidence of pulmonary arterial hypertension to be the same in limited and diffuse. But there are more people with limited because there's more in the cohorts anyway, and because older age and longer disease duration are certainly a risk. So there's a new kid on the block for treatment. So if you were in one of the breakouts, you heard about some treatments yesterday. So we have treatments of various ways of vasodilating, redemodeling the blood vessels, things like that. But there is a new treatment. It's an antifibrotic that restores bone morphometric protein, which is abnormal in certain familial pulmonary hypertension, but it seems to be abnormal, this protein, in pulmonary arterial hypertension for multiple causes. This drug called sotatercept is basically, it's a dual inhibitor. It's decreasing fibrosis, and it's a biological drug. So it's a brand new thing that was published. I've got the thing on the next page. It was published in New England Journal about a year ago. So the outcomes have improved. So when I first practiced, when I diagnosed pulmonary arterial hypertension, the JVP was up to here. There was pitting edema, so right heart failure, and the patient died shortly thereafter. We didn't screen because we had no treatment. Then epoprostenol became available, not very available for scleroderma patients. Then oral drugs became available, and we screened to detect them earlier. So the 1-year survival of scleroderma patients from the US, the Pharos trial, 93%, down to the UK, 78%, so it can still kill people. But look at the 3-year survival. Half of them almost have passed away from their pulmonary arterial hypertension, whereas in the Pharos study, 2/3 are still alive, or 3/4 are still alive. We can do better than this. So a lot of treatment has looked at multi-drug, starting 2 drugs. If you don't meet the target, adding a 3rd. You never take a drug out of the same class, so an endothelin receptor blocker plus an PDE5 or riociguat. You don't combine PDE5s with riociguat. So one or the other of those with an ETA. Adding a prostacyclin, or a prostacyclin plus a PDE5, and then adding an endothelin receptor blocker. So this is really important. And again, if you heard the lecture in one of the breakout rooms, the presenter, she talked about trying to get people to lower risk. So we're trying to get people from high risk to medium risk to low risk. And that's based on their BNP, their walk time, their echo, their heart cath, things like that, whether or not they have heart failure, their response to therapy. So it looks like rheumatoid arthritis or high cholesterol or diabetes, treat earlier, combination, targeting therapy, adding instead of switching. So just like all the other things that we treat. So a clinical pearl here is the treatment of pulmonary arterial hypertension is to change the risk of the patient. High-risk patients die far more than low-risk. Low-risk pulmonary arterial hypertension patients have a far better survival. So we're trying to bring that risk down. If we go on to interstitial lung disease, again, about 30% of patients, half of whom will kill them. Who do we treat for interstitial lung disease? If you heard my lecture earlier, it's like, first of all, we're not really in agreement, but moderate to severe lung disease, recent deterioration, short disease duration, so early, limited, or diffuse. If it's early and you already have lung involvement, we trigger treatment. SCL70 positive has more lung involvement, but not always predictive of progression. Worsening interstitial lung disease, even if you have abnormal pulmonary functions and their ILD on high-res CT is worsening, it will probably trigger treatment. If you think it's from their scleroderma, if it's worsening, it probably is. If it's level for 10 years, it probably isn't, or might not be. Maybe dyspnea. No literature talks about if the patient has equal stuff and one's short of breath and the other isn't, but I treat people if they're short-winded, short of breath. And the histology that was asked about this morning has really no added value in scleroderma, unless if you think something else is going on. So worse prognosis, there are more high-res CT fibrosis going on, hypoxia, obviously, superimposed pulmonary arterial hypertension, then you're really at risk. And those patients can be offered now treprostinil, a positive randomized controlled trial. Before then, they were excluded from all pulmonary arterial hypertension studies if they had moderate or severe ILD. Cough, from the scleroderma lung studies and from other studies, is probably diaphragmatic irritation, but ongoing cough that the patient can't control is usually predictive of bad disease. It could also be from aspiration, which worsens your disease too. And severe restrictive defect is obviously a worse prognosis. So the goals might be for interstitial lung disease, I want to improve the quality of life, I want to prolong survival, I want to change the natural history, I want some reversibility or improvement or stability or slow worsening. The treatment paradigm is immune suppression. If there's ongoing fibrosis, you're going to think of an antifibrotic. If they present with significant fibrosis, you might think of the antifibrotic right at the beginning. Transplantation. Has anyone had their patients get a lung transplant with their scleroderma? So just very few. So again, organ shortages, they don't like our patients because they aspirate into their lungs. They're a little bit older. They're not as old as IPF on average, but they're a little bit older than, say, getting lung transplantation for, say, bad lupus or something. So there's no reason to exclude them from transplantation if they meet the criteria of a site that will transplant. This is showing two things. So this is a tocilizumab lung study, the tocilizumab study to improve skin, but it shows the decline. No decline is the one side, and a decline is the worsening, the other side. You can see more worsening on black, which is placebo, and more improvement or no decline. The curve is shifted on active treatment. And that was found in both the focus, the two studies, phase 2 and 3. So again, these are the goals that I've talked about. Sorry, I'm going in the wrong direction here. So this is the focus. So Fascinate and Focus showed the same things of less worsening. Rituximab versus IV cyclophosphamide, this was published a couple years ago now, shows improvement is better on skin and on lung. And this has been borne out of rituximab versus placebo from a large Japanese randomized controlled trial, and from the Recital trial, which was CTD, connective tissue disease associated ILD, that showed rituximab was also better than cyclophosphamide. So cyclophosphamide is going out the way it's sort of out of fashion or is out of fashion for GPA. So it's the same idea here. And you can see the scleroderma patients, they do get a response on either treatment, or at least equally less worsening on either treatment, but better on rituximab. So treatment with rituximab seems to yield better improvement in subsequent years. What do I mean by that? If I put a person on rituximab in year 1 for their skin and their lungs, I can tell you if they're responding, I will keep giving it regularly, maybe 1,000 milligrams every 6 months, maybe even 500 every 6 months. And by the time you get to 3 or 4 years, I am really impressed at how much better they're doing. But if I don't treat them ongoing, I don't think they do as well. And obviously, if I stop treating them, it's because they didn't respond or they've had a bad side effects. But certainly year 2, 3, 4 is better on rituximab for skin and lungs clinically. Nintedanib we've talked about for progressing pulmonary fibrosis phenotype, worsening on placebo, less worsening on nintedanib. The pirfenidone study did not show any difference. It was underpowered, but it was definitely a negative study. It was underpowered because of COVID. The recruitment went slower, but this was just presented at the American College of Rheumatology. And unfortunately, pirfenidone doesn't look like it's doing anything in this study compared adding to mycophenolate or mycophenolate alone. What about progression of interstitial lung disease? Please give anti-reflux procedures. Patients who aspirate in their lungs will worsen. Patients who are choking, waking up with vomit in their mouth, or needing esophageal dilatations will worsen. Having stomach contents in your lungs is bad for your lungs. No kidding, but it is. More progression. Then this is a study, so I said we're really not sure in mild lung disease if we should give immune suppression. I think give me a reason not to treat. If there's no reason not to treat, why not treat? So our Canadian Scleroderma Research Group showed treating mild lung disease with mycophenolate mofetil, the patients did better than not treating over the next few years of follow-up. A small randomized controlled trial, short-term, found no difference. Short-term, very small. What about vascular changes in Raynaud's? The bottom line is keep warm, stop smoking, wear a hat, wear your mitts, stay warm and stay out of the rain here, stay out of the cold. Don't live in Bogota, I guess. Stay out of the cold and don't move to Canada. But basically, calcium channel blockers, nifedipine is the main one. Looking at PDE5 inhibitors or prostacyclins. That would be similar in a way for digital ulcers. Because I talked about it before, I'm not going to talk about that. Heart involvement, don't have a clue how to treat it, but there's two problems with cardiac involvement. One is heart failure, cardiomyopathy, a pump issue. The other is having an arrhythmia, sudden death in our patients. So how do I do it? I'm looking on an echocardiogram. So the echocardiogram not only estimates the pulmonary pressure, it does a beautiful echo of the left heart. So I'm looking for things there. Then just borrow standardized treatment for those issues, a pacemaker, a defibrillator if you have a ventricular tachycardia, treating heart failure if you have LV, left ventricular hypertrophy or left ventricular failure. Gut involvement, the main thing is don't eat after supper time if you have gastroesophageal reflux disease, which is usually quite bad in scleroderma. Proton pump inhibitor, double the dose off-label, triple the dose off-label, maybe even quadruple the dose if you have to. Pro-motility drugs, H2 blockers, sulcrophate. Those are the kinds of things we do. Small intestinal bowel overgrowth, you're going to think of antibiotics cyclically. Do I do a hydrogen breath test? No, I do a history and a physical. If I think you have SIBO, small intestinal bowel overgrowth, I try antibiotics for a week, see how long it helps to knock down that bacterial count. It will, of course, come back because you're neutralizing acid in the stomach with my 4 times the dose proton pump inhibitor, and you have nothing contracting normally. It's just kind of sitting there. So you will need it cyclically in many patients if it works. Incontinence, very difficult to treat. Colonic obstruction or colonic related diarrhea, you still need to get the bowel moving. So we're sometimes using laxatives for the large bowel involvement, and people say, but I have diarrhea. And I go, because your whole large bowel is sitting there like a pipe instead of a nice muscle. So get your help from your gastroenterologist. Just to finish here, scleroderma renal crisis. Has anybody seen scleroderma renal crisis? Okay, so we have about 8 or 10 hands, maybe 12 hands. So scleroderma renal crisis, you must recognize it or that patient could die. They get on the wards, everybody knows they're anemic, everybody knows they have a bad GI tract, everybody's looking at their digital ulcers, and they're forgetting that their blood pressure that was 120 over 80 is now 240 over 110. They just become blind to it, including nephrologists, which I find is interesting. So you have to think about it. RNA polymerase 3, if you can get that in your ENA. Early disease, especially diffuse, more in men, more if the skin is rapidly progressive, more if you already have internal organ involvement, but sometimes it's the first presentation. So most will start with new hypertension, 10% won't, so you're going to miss them. We can't help that. Half will have increase in creatinine, and half will have obvious evidence on peripheral smear of microangiopathic hemolytic anemia. So only half will have the creatinine going up. Only half will show the intravascular hemolysis from the red cells shearing from the severe clamping down in the renal arterioles. So interestingly, giving an ACE inhibitor does not prevent renal crisis, but the treatment is get the blood pressure down as fast as possible with an ACE inhibitor, full dose, day 1, and add whatever other treatment you need to lower the blood pressure. So that is the treatment. Why ACE inhibitors? It's because they have pro-bradykinin, a potent vasodilator. ARBs, angiotensin II inhibitors don't, and they have a high mortality. So it's not just the anti-renin or anti-aldosterone effect, it's actually the pro-bradykinin, which by happenstance ACE inhibitors have. So the risk factors are early on in disease, diffuse, way more than limited, rapidly progressive, earlier disease, men more than women, RNA polymerase 3, glucocorticoid use, and we don't really use it, cyclosporin, but if you're using tacrolimus, it can increase the risk. It's also often associated with a pericardial effusion, probably because the lymph channels and veins can't drain around the pericardium of the heart because of the high sudden hypertension. So you have to think about it. So in all early patients, I get them to do home blood pressure monitoring, but particularly the diffuse, particularly if they're a high skin score to begin with. I avoid glucocorticoids if I can, and I tell patients, we think of it like pregnancy-induced hypertension. If someone is a mom that's expecting a baby and they go toxic, toxemia is only a small change in blood pressure. So I say, if your blood pressure is always 100/70, if it's 140/85 and you repeat it and it's like that a couple times in the day, I probably need to know. I'd rather have a false positive, they come in and get looked at, than miss the 220/110. Because renal crisis isn't overnight. It's a bit of a trend happening for most people over probably a series of weeks. Renal crisis, ACE inhibitor, get the blood pressure down quickly, then add whatever you feel like adding. Calcium channel blocker, alpha beta blocker, PDE5, whatever. Just get the blood pressure down, but keep the ACE inhibitor going even if the creatinine is going up. What about inflammatory arthritis? So about 15% of our patients have inflammatory arthritis with scleroderma. Musculoskeletal complaints are far more than that. But you're going to think inflammatory arthritis, non-steroidal anti-inflammatories, maybe low-dose prednisone if someone can't even bend their hands to get dressed in the morning, or they can't work on their computer because of that. But I try to avoid glucocorticoids if I can. We really need the hand therapist to help us. And then I just make it up. If it looks like it's erosive inflammatory arthritis, 3% of scleroderma overlaps with rheumatoid arthritis. I just treat it like RA. If it looks like a mutilans, I treat it like psoriatic arthritis mutilans. If it looks like a lupus overlap or non-erosive, I treat it like lupus. So in other words, it's all made up. Just use whatever drugs you like and see if they help. So that's what we do in a lot of diseases such as scleroderma with inflammatory arthritis. I can't stress how important it is to have hand therapy for our patients. So who has access to a hand therapist for your scleroderma patients? You can put a referral and have it. So very few patients. So I'm part of a network of scleroderma patient intervention network. It's on the internet, and there are free modules now in many languages to show our patients proven hand therapy. It's the SPIN network, and that's really important because if you don't use it, you'll lose it. And once you have a claw hand and your tendons have withered away, it's not coming back. So hand therapy is really important. Randomized controlled trials of hand therapy in general in scleroderma are positive, more than just saying, here's what you should do and off you go. You need to reinforce the hand therapy as you go. So there's more positive than negative studies in the bulk of the literature. So I've gone through multiple organ involvements. I don't know what to do for calcinosis, so I hid that slide. It's a big question mark. But you can see every aspect of a patient's life might be affected by their systemic sclerosis. Their ability to work, to eat, to care for their families. The itch can drive them crazy early on. The GI tract complaints, the calcinosis, the diarrhea, the bloating, the fecal incontinence, the skin manifestations that can break down and give ulcers, the pain, the fatigue, the erectile dysfunction in the men and poor sexual health with dryness in the women, depressive symptoms, you name it, it's all there in some of our patients. Fortunately, not everyone has everything. So this is no different than when we're treating other systemic autoimmune diseases, such as looking in lupus or looking in even patients with RA and psoriatic arthritis. We need to look holistically at the patient, get help where we can. We're not experts in everything, so get help where we can. So we've talked about the vascular complications a little bit, But different vascular beds have different treatment. Renal crisis is treated by ACE inhibitors and then adding anything to get the blood pressure down. Whereas the vascular changes at the hands or at the feet, the distal digital arterioles are treated by calcium channel blockers. Interstitial lung disease and skin may indeed be treatable. There are many GI, gastrointestinal treatments. Most are off-label. And I can say very proudly that research is probably now finally catching up. That these days, interestingly, there's more randomized controlled trials registered in systemic sclerosis than in mechanical back pain. Super common, super rare. We're learning way more over the last several years in scleroderma. And I can never thank people enough. Thank you for listening, thanking always the patients and thanking the funders and my hospital and my university and, of course, my research collaborators, coordinators, and the many medical students I've had the ability to mentor. So with that, I thank you, and we'll open it up for questions.